I got to go. Thank you for your patience. I am Darren, and I will see you now. Darren is a symbolic name. Darren symbolizes the critical role that every stakeholder plays in our collective fight against HIV and AIDS. Darren represents all of us. We're used to doctors being the ones in a position of power, the ones with the knowledge, the insights, the answers, and the wisdom. But the same can be said of people living with or affected by HIV. It's time to flip the narrative and challenge expectations. I'm Randy Davis. This is supposed to come off much easier. It was my big reveal. I'm Randy Davis, and I'm a person living with HIV. I hold vast expertise, unique insights, and experience. I have the power to drive change, and I will see you now. Today we want to talk about changing the dynamics in HIV, to put people first, and what that really means. Person-centered is something we hear more and more about these days, but it doesn't really cover it. It's not about being at the center. It's about working together as equals, person-partnered care. We're going to begin with a little bit of instructions for the audience for our polling that's going to be happening throughout the symposium, as well as our Q&A that will happen at the end of the session. So let's test our polling system here. If you scan the QR code that you're seeing on the screen, that will get you access to the Slido app. Please use this to take part in the polls and submit your questions for the Q&A in advance. So let's give this a test. Once you've scanned the code, our first poll is, which term do you prefer? Person-centered or person-partnered? We'll talk about this concept of person-partnered care in the context of medicine development, healthcare provision, and community advocacy. These three pillars are the foundation to ending the epidemic. There are other factors and other stakeholders involved, but this is where we start. We must keep an eye on what happens as the baton is passed between them. So I'm seeing, as the Slido poll comes in, a preference for person-centered over person-partnered. I disagree, but that's just me. So in my waiting room today, before I do that, we've got a hashtag, Put People First. You've seen it all around the conference, and you'll see it throughout the symposium as well. Please use that when you are posting to social media so that we can share all of these insights and thoughts together. But in my waiting room today are three people who also hold vast expertise in HIV. We're going to meet them now one by one and get a little more insight on what's driving them in the field of work that they do, how they view the current dynamics, and what it will take to change. The first person I would like to introduce to you all is Dr. Kim Smith, the head of research and chief science officer at ViiV Healthcare. Kim? Come join me on stage, Kim. How you doing?
I'm great, Randy. How are you?
I'm well, thank you. So could you tell us where we are now with medicine development in terms of partnering with people and exactly what that means for folks at ViiV Healthcare?
Well, I'll start with sort of why I feel passionate about this sort of patient-centered, patient-partnered, person-partnered. And I feel passionate about it because I spent 20 years before I joined industry as an HIV treater and provider. And, I heard I heard their experience, I heard their stories. I had many tools in my hands, but I didn't have all the tools that I needed. And what I found in many cases was that the information that was coming wasn't actually patient-partnered, wasn't person-centered. And it often didn't represent all the populations. And so it didn't often include women. Didn't often include enough people of color in all of the diversity that exists in our community. And so I joined industry because I wanted to bring those voices and make sure that we understood the needs of people living with HIV, people who could benefit from PrEP, people who were impacted by HIV. I wanted to make sure that their voices were in industry and that we made sure that our clinical trials reflected those individuals and that we developed medicines for people's needs, not just develop medicines, without really hearing those voices and addressing what people's needs were. So that's sort of where we are in ViiV, is that we listen to the voice of the patient, we listen to the community, and we use that information to help us decide what types of medicines, which medicines we develop, and how we develop them. And so I actually have a video I want to share with the group that actually gives a little bit of an example of some of the work that we do. So we have recently developed a long-acting prevention medicine. And we really wanted the trials to reflect the populations most impacted. And we wanted to find ways to have the folks that participated in those trials feel included, like their voices were heard, like they got to drive things and feel empowered. And so I hope this video helps you understand a little bit of that experience.
That's great. Let's cue that up for the audience to see.
22 years ago, when we first came here and we said we can stop babies being born with HIV, and we did that. And then we said people can live a normal life when we give them antiretrovirals, and we did that. And today we claim that we can stop people getting infected with HIV, and we will do that. We now have the opportunity for choice.
Having a choice, man.
Do you feel like it made you feel empowered?
It has strengthened me, it has empowered me, it has shown me how worthy I am.
I love that. I love that. I love that. What I want to say is thank you, because of you and all of the people like you who were willing to give of yourself to be a part of this trial. We're going to change HIV for the world.
I think.
Can I have a hug? Thank you so much.
Thank you.
So stories like hers,
Yeah.
where actually being empowered because she had access to PrEP, and that made her feel more worthy. Oh my God.
Yeah, it reminds me very much of the U equals U message and how empowering that is for folks living with HIV.
Exactly.
And I think that's a great description or a great interpretation of the passion that ViiV has for folks living with HIV and affected by HIV. And certainly it's a demonstration of your passion in the field as well. So thank you, Kim. I appreciate that. We'll talk to you again later when I have my consultation. So next up in my waiting room today is Dr. Benjamin Hempel, Chief Physician and Co-Director at Checkpoint Zurich. Ben, come on to center stage. Good to see you.
Randy.
So my question for you is sort of twofold. How did you end up in the field, first of all? And where are we now with seeing the change in dynamics?
Yeah, I mean, to answer the first question, I probably have to be a bit personal, share some experience. When I was at med school, my partner by the time got really sick. So he's living with HIV, and in that time, we waited until CD4 count drops, and we waited a bit too long. So we spent a lot of time in hospitals, in waiting rooms, in doctors' offices, and I kind of figured out what worked for us, what helped us in this really critical situation, and what was maybe not so helpful. And then later, when I was a doctor, I thought I could actually implement this experience in my daily work as a doctor, but I found it quite challenging in the classical medical world. So luckily, then I was offered a job at Checkpoint in Zurich. And for those of you who don't know, the Checkpoint is like an initiative that was started 20 years ago. First one was in Amsterdam, where actually gay men wanted to prove that if you offer HIV rapid tests in a community welcoming atmosphere, MSM come more for testing. And Checkpoint Zurich went one step further, also treating people living with HIV, and now we also offer hormone replacement treatment for trans people. So in this environment, I felt much more comfortable and welcomed in a work surrounding that was actually founded by the community. So I still feel kind of hired by the community. Right. And here, this goes through everything that we do, from the way we talk to our clients, what language we use, but also if you see in the picture, the architecture. So we were lucky we could move last year to a new building. And the architect is actually one of our clients. And by just getting inside this building, you don't feel like in a classical clinical surrounding. Queer people do understand the reference of the mirror balls representing the 80s and 90s club culture, where HIV were so important for the HIV movement in that time. So I think your question, where we're going now, where the development is we're super successful. Sometimes we grow a bit too fast. So this whole different mindset that we first have to learn. And sometimes, we need a bit of time for that.
Yeah, and this is a great representation, I think, of what that person-partnered care should look like for community by community. So I really appreciate that. I thank you for this brief conversation. I'm going to send you back to the waiting room, but we'll have some time in the consultation chairs very soon. All right, thanks, Ben. Next up, I'm not going to say save the best for last, but if anyone knows Judy Oddie, you'll know that's probably not a bad statement to make. So our third panelist, Judy Oddie, the head of HIV services at the Africa Advocacy Foundation. Judy, join me on stage. Welcome.
Thank you, Randy.
Good to see you. I'm glad you're here, safe and sound, despite all your travel issues. So, what does person-partnered care mean to you, and how have the dynamics changed in the community, and where are we going next?
I'll start with, I'm with you on partner-centered, as opposed to people-centered. But anyway, in terms of, that was back to the poll. But in terms of what it means to me, I think the work we've done in community, a lot of voices we've heard is messaging that they see doesn't reflect them. They don't see themselves in the messaging. So I just thought I'll share a bit of what we've done. If you look at these flyers, that a snapshot of what we've done, they're vibrant, they're colorful, people are smiling. The messaging, the words, the tone, we've tried to make sure we pitch it, and context is all based on what we as a community feel would like to be portrayed, how we engage. We've used universal languages, like with PrEP Hakuna Matata, with PrEP No Wahala. These are universally understood, and that makes it more resonates and normalizes these conversations around prevention and testing. And then to your second question, I think, again, to emphasize why it's really important for the community to see themselves in our messaging, we created a video. And this video, in order to produce and make sure that it was meaningful and impactful, we looked at language, we looked at the imagery, we looked at, and we're going to show you the video in a minute, but, looked at language, looked at the prompts, and I just want you to watch that, and I'll point you to a few of the things that made us make sure we made it impactful.
Awesome. Let's cue that up for the audience.
Hello, Mom. My baby returns home. Tell me everything. I received a video from Lillian today. A drug called PrEP or something.
Yeah, PrEP is great.
It sounded like it would be good for your brother when he's going out gallivanting the streets.
PrEP's good for men, women, non-binary people, well, for anyone who's sexually active or feels an extra risk of contracting HIV.
Women take it too? Isn't that a bit unladylike for women to prepare for sex like that?
You could say it's a humanitarian act, Mum, like wearing a mask during the pandemic to help stop the spread of coronavirus. Across the UK, over 100,000 people live with HIV. By stopping yourself from contracting HIV, you're also helping to prevent the spread of the virus.
So much has changed since I was growing up.
So very quickly, you could look at the tone, you could look at little things, the bag of rice, for some of you who are observant, the language she uses, and the contrast to mother and daughter conversations. And this was really key in trying to bring the message of embracing PrEP as a prevention tool.
Yeah, again, another example of by community, for community. I think it's brilliant, so well done. Thank you very much, Jim. I'm going to send you back to the waiting room for now, but we will have some one-on-one consultation time very soon.
Thank you.
Thank you. So, just a big round of applause for all of our panelists and those brief introductions. Thank you. As I mentioned, and if you haven't noticed, we've tried to set the stage up as a mock doctor's office. So while my panelists are currently in the waiting room, Dr. Darren is heading over to the consultation room where we will have a little more in-depth conversation with each of the panelists. So thank you again. I'll move my lab coat out of the way. We're all stakeholders in the fight against HIV. People like me, living with HIV, people like Kim, who work in medicine development, people like Ben, providing healthcare, and Judy, working with community. I'm Randy. I am Darren. Darren represents all of us.
Dr. Smith, please make your way to the consulting area. Randy will see you now.
Well, that was Dr. Darren. We'll call you Kim.
Dr. Darren, I'm down.
Right.
I'm
Thank
down.
you, Kim. Welcome. Welcome to my consultation area.
Thank you.
So my first question is just around the design of medicines. And I need some concrete examples of how people partnered ViiV really is in the development of medicines.
Well, I think there's so many layers to development of medicines. First, you have to understand the communities and the needs of folks. And so how do we go about doing that? Well, we have all sorts of community advisory boards and all of that where folks give us advice on, what they need. We do in-depth surveys, not saying, do you want this medicine versus that medicine? Actually asking people about their lives, about their needs, about the challenges that they experience in their lives. And we learn, we do one every year. We do something called the Positive Perspectives Survey, which surveys thousands of people living with HIV to really try to understand, their experience. And some of the things that come out of it are, you wouldn't necessarily call them directly associated with medicine development, but they actually teach us things that make us think about the type of medicine that we need to develop. So, for example, in those studies, you see as many as 77% of individuals saying that they don't feel comfortable with talking about some subjects with their docs. You have as many as 60% of people saying they regularly hide or disguise their medicines in order for no one to see them so that, they're not disclose that they're living with HIV. We learn lots of things about, how much do people understand about U equals U, and what are their motivations for being on medicines? What are the best types of things that they would like to see? Do they want medicines that have longer intervals? Do they want to take medicines every day? What are the things that challenge them? What are the things that impact them negatively? What are the things that make them feel stigmatized? All of those types of questions. So you start with that big picture, and then you go about taking medicines and saying, okay, if I want to let's say I want to make a long-acting medicine, let me think about how would I go about doing that, and what is the design for the study. And when you start designing the study, you include the community in those descriptions, in those designs. So you don't just, sit over in the ivory tower and say, this is what we're going to do, right, and then just bring it to people. You actually come up with ideas, bring the community in to say, what do you think about this? And, we learn a whole bunch of things, like, some minor, you might think of it as a minor exclusion criteria that could impact a lot more people than you think. So it's those high-level things that start out with how you design a trial, but you're intending to try to address what are folks' needs. And then ultimately, when you get to a design, it's actually making a commitment that the populations most impacted, and often, underrepresented in the trials, that you make a commitment to keeping to getting those folks into the trials. And so that to me is at the core of how you start thinking about designing studies to make medicines.
So is it safe to say community insights lead
Absolutely.
to innovation?
Oh, no question. Our innovation, when we move from 3 drugs to 2 drugs, we moved from daily to long acting. That is all from folks telling us what they want. And then when we do the trials, we incorporate surveys within the trials to have folks tell us about their experience. And so then you'll hear us talk a lot about, we use the acronym PROs, or patient-reported outcomes, or participant-reported outcomes. And it's to make sure that, we hear from them what their experience is being on the trial with the medicine. And so it's not just, does the medicine suppress your virus? That's a given. That's the cost of entry. It's what else can it do to improve their life experience and make their experience with living with HIV less and less. We say we want to make HIV a lesser part of their lives. And so how do we do that? And so we go about that by understanding what people's needs are when we're designing the medicines and designing the trials, making sure we hear from the people that are in the trials, and making sure that the right folks, a diverse group of folks, are included in the trials.
And do you have any examples of specific drugs that have been developed in that manner, and folks that have been involved in these trials that actually represent who these medicines are targeted to?
Sure. Well, we commit to, really with all of our trials, one, for people living with HIV, you often see the clinical trials have low numbers of women, like ridiculously low numbers of women. Now, yes, in parts of the world, you may see, like in the US, roughly 20 to 25% of people living with HIV are women. In other parts of the world, though, it's more like 50% or more. And so if you have to be thoughtful about where you go to do the trial to make sure that you represent it with women. If you just go to the places where it's mostly men, you're going to end up with a trial that's mostly men. You're not going to answer the questions for women. And so we make that commitment to make our trials diverse. But I think one of the best examples, actually, and it comes back to the development of long-acting PrEP. When we did the study that was focused on men who have sex with men and transgender women, we made a commitment that the men that enrolled in the U.S., we were going to make sure that at least 50% of those men were Black MSM. Because, one, Black MSM are disproportionately impacted by HIV in the United States and are consistently underrepresented in the clinical trial. Absolutely. So we made that commitment, and we delivered it in the clinical trial. We also made the commitment it was going to be at least 10% transgender. And we were we're able to do that too. So we could answer questions for those communities, and then you go to the communities with the data, and actually you're talking about their experience as opposed to trying to describe an experience from somebody else and sort of say, we think it'll work for you too.
Right.
Yeah.
Yeah. That's great. That's great. I think we have a polling question that we're going to turn it to the audience now. So as that comes up on your screen, I'll read it out, and then I'll maybe get some thoughts from our folks over in the waiting room there once we have the results of the poll. So, which of the points that Kim has just mentioned resonated the most with you? We need more medicine to provide more choice. Innovate with people, not for them. It's more than unmet needs now, it's wants and desires. Partnership is key. Listen to people. So maybe while the audience is responding to that question, Ben and Judy, I'll ask if you have any thoughts on what our discussion has looked like so far.
Yeah, I mean, the one topic you said, Kim, is definitely the role of transgender people in the clinical trials. I mean, that is something that we see in our daily life as a clinic prescribing hormone replacement treatment. So very often if you offer PrEP or ART, the first question from the transgender people is, how does it affect my hormone therapy? And it's really nice to see what kind of effort ViiV does approaching us, which is not a universal center for clinical trials, to also make sure to include trans people in the trials. Yeah.
And not having trial sites that aren't all at universities and academic settings. It's actually representing the wide splay of folks who are living with HIV and get their care in many settings.
Yeah, that's great. It's the whole idea of meeting people where they're at.
That's exactly right.
Yeah, so wonderful. Well, let's take a look at this poll question here. And it looks like we have a majority winner here of innovate with people, not for them. I don't think any of us disagree with that. And I think these are poll questions that I think we could probably have a fifth option of all the above as well.
Absolutely. I think it absolutely is all of the above. That, if we try to innovate based upon what folks who are not living the experience, we're going to be off all the time. We're going to be delivering things. The last thing anybody wants to do is make medicines that people don't want. We want to be making medicines that people want, that improve their lives. And we're at a point in HIV where, again, getting the virus suppressed, lots of medicines can do that. We got lots of options for that. But how do we actually go beyond just getting the virus suppressed to impacting people's lives, improving their quality of life, actually maybe even making them feel less stigmatized? All of those things are on the agenda for what we're trying to do when we make medicines. And so, if we go back to the old days of, just whatever can drive the virus down, forget the side effects, forget the impact that it has on people's lives, nobody would be interested.
That's the wrong direction.
That's the absolute wrong direction.
Absolutely.
And so innovation has to include people. And then partnership is a given. I mean, it's, and when I say partnership, it's partnering with community organizations and all that. But also, in ViiV, there are many people who are living with HIV who are employees of ViiV. Many people impacted, many people who could benefit from PrEP. And so, we are a part of the community, not outside of it. And then more medicines for choice so that people can, have the options for what fits best for them. Because there is no one size fits all, no question about it. And so, I think we try to be creative and we try to listen. And, we always want to hear from folks, complaints or compliments. We want to hear it all.
Well, sometimes those complaints drive innovation as well, right?
Absolutely. If I only wanted to hear the good stuff, then we wouldn't make innovation.
Exactly.
And so innovation means responding to things that aren't right and actually saying, when somebody says, this is something that I like, how do I make more of it? How do I make it better? And so when I think about, for example, long-acting treatment, what have I heard from folks? Folks say, we love long-acting. We want more. We want the interval longer. We want, and so I start getting Janet playing our mind. What have you done for me lately? So it's get better and better, and that's our goal.
That's awesome. That's the soundtrack I want to hear from ViiV. Absolutely. So thank you very much. I
Thank you,
appreciate
Randy.
it.
Dr. Hampel, please make your way to the consulting area. Randy will see you now.
The doctor seeing the doctor. Another one.
Hey, Dr. Randy.
Good to see you, Dr. Ben. Have a seat. All right, so a few questions for you as well. You mentioned how personal this work is to you, and I think it's personal for all of us, but there's that connection that is undeniable in the work that you do. So how do you go about changing hearts and minds in the healthcare setting, and what's worked best in your experience?
Yeah, I think it's a process. It has several steps, I think. And the first thing is, so if you are a healthcare provider or a doctor or anyone working in the field, there's a certain role that we have in the society, driven by movies or other ideas that we have. But the doctor, the superhero with the magic skills, and you really have to unlearn this idea because we're not. And I think that's one of the hardest parts. To give up this idea, but then you can start listening to your clients. You can learn about their idea of what kind of concept do they have of health and stay healthy, what motivation do they have, and also what's their background from their biography. And then when you have this, you can start creating a partnership and working together. And maybe give you an example, we know that people, especially from the key population asking for post-exposure prophylaxis, once they already asked for it, they show a very high risk of getting HIV at a later point in their life. And why is this so? It's a good question, because they already proved that they know that they need protection, right?
Sure.
So if you ever had to have a PEP, and probably you had to go and get it in an emergency room, where the doctor was super stressed out because there were 3 more heart attacks and another stroke, and probably you also got lectured about your behavior. So you might not want to go back in this situation next time it happens, right? So, and what I start always with the first question when someone comes in our clinic and asks for PEP is, how was the sex? Was it good? Because we know using a condom is more difficult when the sex is really good. So, and I think with this little question, you see always then the relief of the client sitting in front of you, seeing that I know where this person is at the moment and that they don't have to fear to be judged or anything else. And that's a very little thing, but it makes a huge difference.
Absolutely, yeah. And I know early on after my diagnosis, I quickly learned that as someone living with HIV, I have this responsibility to advocate for myself in the healthcare setting and talk to my doctors about what my needs are. And I'm wondering, how do we amplify the voices of folks to ensure that they have a way to advocate for themselves as well?
Yeah, I mean, I can also always just, speak from my side. What can we do on the healthcare provider side? And there's a lot of things we actually can do to make those changes. And it's always a good thing to start with language, because language can change your mind and the way you think. So, for example, we developed a sort of language, what we want to use in our clinic, especially which is a trans-friendly language. And every new employer is trained in this language. So I think that already makes a change. So we use the word client and not patient. However, this can be also a bit tricky because sometimes people misunderstand client with customer. And it's something that we see, I think, in healthcare in general, that we want to be partners and we end up as service providers. And so you literally fall from one toxic relationship to the other one. So it's a thin line to really become partners, because we also want to be partners. We don't want to just serve. So yeah, language is one part. Then education. So we also train young doctors at our queer health centers, and I think they learn something else than they would never learn anywhere else. You could implement those mindsets into guidelines. So in 2018, when I wrote the first version of the PrEP guidelines for Switzerland, the Federal Office of Public Health wanted me to give clear indications. So who gets PrEP and who does not? Like, this is not how I think.
Right.
You know, like, so I refused to do that. I wrote the first sentences. PrEP is a very personal decision, and the healthcare provider should not do this decision for the person. But they should guide them in this decision process and provide them with all the information they need. And I hope this, changed something in some healthcare provider. And I think last but not least, research. If you want to be seen in the medical field, community centers like us need to do their own research, not just participate in big clinical trials, but also create our own study design, because we all know what kind of questions we can ask the people and how we get high acceptance in research.
Yeah, I think you've just given some great examples of the definition of people-partnered care.
Yeah.
And certainly talking to folks and showing them an example of someone who is living a similar life and asking that question, how was the sex? Mm-hmm. How many doctor's offices do you walk into for a sexual health appointment and they ask you how the sex was? I don't see any hands being raised, so not many, right? No, absolutely not. So how do you translate that same mindset to areas beyond PrEP and PEP?
I think you're right. I think it's a mindset. It's not so much the difficulty in the resources you have. It's more once you change your mind and you unlearn the role you have, then you can do actually literally everything. It doesn't matter if it's cancer, treating HIV, or anything else. I just see the slide from the example that I also wanted to share, because this shows really nicely how you can combine this people partnership and healthcare and research, because a couple of years ago, we managed to get funding to offer free PrEP for male and trans sex workers. However, they didn't really show up. We were wondering, why is that so? Because by that time, people had to pay for their own PrEP in Switzerland. So we looked around, what is the problem? Where do sex workers in Switzerland go? What are the life reality? And we found an organization which is centered in the red light district, opening at night, where they offer consultations about social problems. For example, if they have problems with the housing, if they have problem with the police. And here we found the sex workers going. So we asked them, can we go there and offer PrEP in your night consultation? And they said, yeah, let's do this. So we did not just change the location of our service and the time where we offer it so that it matches this community. We also said, okay, we have a different process. We do a rapid HIV test. If it's negative, we start PrEP on the same night. And many people said, oh, you're crazy. You're giving ART to people and you don't know what happens to them. So I thought, okay, let's ask the sex workers if they want to participate in my cohort so that I can follow them. And the acceptance was super high because they understood what we're doing. And around 90% showed up to the follow-up consultations. And I think very critical here was that we created a relationship with the community, with the sex workers, so that they build up some trust, and then they found their way back to our clinic.
Yeah, and that building of trust, I think, is key in healthcare settings.
Absolutely.
Yeah, and again, a great example of how that can translate into other areas. So thank you for that. We've got another poll question. So Kim and Judy, I want you to pay close attention to this poll question because I'm going to ask for your feedback on this. So which of these points resonated with you the most? Shared decision-making should be the norm. Give people a choice is crucial, giving. Person-partnered HIV care is possible and improves outcomes. We need to adapt to people's practical needs. Now, while we're waiting for the poll question to respond here, Judy, Kim, any thoughts on what Ben's had to say?
I think with Ben, and this is what we are seeing, again, when we talk about partnering and involving, you talked about research, Kim, earlier. It's meeting the service, where they want them call them service users, your target audience where they are. When I speak to women, women don't get enrolled in the trials because the specifics of the trials don't suit their needs. So how about we turn that on its head and meet the women where they are? In a program I'm going to talk about later, we did a training with women, and we had women come with their babies tied on their back, and they were trained as peer mentors. How about we meet the women where they are to engage them in the service? And that's what Ben's talking about, going to where the cafe was, and you will engage the service users.
Yeah, if you build it, they will come, right? So I'm seeing the results of the poll. Shared decision-making should be the norm. Shocker. Yes? No. What are your thoughts on that?
Groundbreaking.
Yes, right.
But I think it's all of the above here, too.
Yes, absolutely.
I mean,
absolutely.
so, I mean, this is one of those, when you take one of those, board tests or something like that, and they asked you, they had that word, which one's most, and you hate those because most is all relative, right? But I think the reality here is that it is really all of the above. We should be trying to make sure that we're connecting in all these ways.
Yeah, I agree. Or in most cases, the answer is always C. If it's A, B, and C, C is the right answer. Thanks very much, Ben.
Thank you so much,
all your
Freddie.
insights. That's great.
Judy Otti, please make your way to the consulting area. Randy will see you now.
I'm going to call you Dr. Judy, just for consistency. Good to see you, Judy.
See you.
Welcome to my consultation room.
Thank you.
So, do you think that people are more included and involved in decisions and processes that actually matter?
I'm going to talk from the perspective of Black communities, and I think reflectively, Black communities don't feel heard, don't feel seen, don't feel involved. So I believe a lot more needs to be done to engage, and whether it's around educating, around treatment literacy, so that it enables the community to engage, simplifies the medical terms and the messaging, understands the needs from a culture complex and competency approach. So I think there's still a lot that needs to be done in order to engage this population.
Yeah, I think, again, that's another example of the work we do has to be by community, for community. So having those consultations with the people that we say we are looking to help and innovate with, that's the important piece that is often missing.
It's really important to hear those voices throughout the process and not just at the end when you cannot change what has been developed, but meaningfully through the process. And the key word is meaningful. It can be relevant when a relative using the word meaningfully, but if you involve people from every level of the process, then the likelihood is that whatever the outcome is will be inclusive and welcomed, as opposed to for us, without us.
Yeah, I think that leads to the whole concept of MIPA and JIPA, the meaningful engagement of people living with HIV, the greater involvement. And I think we often lose sight of the meaningful part of that and just focus on involvement, and we get discouraged when we don't have community involved in studies or as part of research. But it's because we've missed that meaningful engagement piece, and I'm a firm believer that has to come first. Meaningfully engaged community, they'll see that, the trust will be built, and then you're going to get the greater involvement.
I think there's always been a perfect patient, and I don't think a perfect patient exists. We've really got to work with real patients and looking at clinical outcomes. Yes, you can achieve clinical outcomes, but a real patient has other needs outside clinical outcomes, and how do we address those needs?
100%. So how do we keep innovating within the community?
It's more about involving, so particularly Black communities, African communities, migrant communities. Language can be a barrier, so it's about upskilling these communities and helping them understand how they can contribute, because sometimes the barrier is they don't feel they can contribute. But how about you take the time to upskill them so that they can then be able to contribute instead of looking for those who are already able to contribute. It's simple things like you want to run a survey. For some people, going online is a barrier in itself. How about you do assisted interviews? How about you facilitate and have conversations? You will still get the information you need through a conversation instead of looking at structured surveys and SurveyMonkey that become a barrier for people where language and accessibility to the internet are issues.
So do you have some examples of how you've done that work and given like culturally competent examples of how we can actually reach community so that we do get that meaningful engagement and therefore the greater involvement?
Emphasizing on how we hear the community voice. I think it's we think outside the box. It's about having conversations in, hair wrap sessions. You call the women in and say, we're going to learn how to do head wraps. And through that, you have these conversations. Those conversations are more meaningful. They're people feeling at rest, at ease, and you will hear the real nitty problems and hurdles that people are going through, as opposed to saying, we're holding a focus group, we're giving you 25 quid, come and sit down and tell us what you think. That doesn't bring the results you need. So it's things like that.
Right, but always provide food.
Hot food.
Hot food, okay. Hot food. That's the big takeaway that I'm leaving here with. Hot food, yeah, that's great, that's great. I think we have another poll question that is going to come up for the audience that we will all discuss when those results come up. But so which of these points resonated with you the most? Partnerships reduce stigma and discrimination. Improved health literacy empowers people affected by HIV. Clear materials should be co-created with communities. Focus on discussion with underrepresented communities. I think, again, all the above could be very applicable here, but I'm going to ask Kim and Ben for their thoughts, not necessarily on the poll question right now, but maybe some thoughts on what Judy's had to say.
Well, I think what you said about, sort of listening to the community and hearing the community's voice and individuals and why participating in a trial might not feel like the right thing, just digging deeper to understand that you may be designing trials in ways that automatically make it exclusionary for people. You make your times when they can come during work times. Folks can't miss work. You don't have an opportunity for them to come and bring a child, for example. Doing it to traditional trial ways is going to disproportionately exclude women, for example, of childbearing age, or women who have children, or people who have jobs that don't have the freedom to be able to be away from work. And so we have to be creative about finding ways that we can make trials flexible enough that they can meet the needs of the wide diversity of folks who we want to participate. Otherwise, they'll look just like all the old trials. And so if we're trying to do something different, I think the point about meeting people where they are and being creative about how we reach people is a critical piece.
Yeah, I think it's interesting too that in these conversations we're seeing a lot of interconnection between community and medical development and healthcare providers. So again, I don't think it's rocket science, right? It's treating people like people.
It's treating people like people. And let me make one other point, and that is that oftentimes we hear a lot of excuses from pharmaceutical companies and other researchers that folks, particularly communities of color, aren't interested in participating in clinical trials. And I think that stereotype is old and tired. And so, because if you dig deeper, what you find is that if you ask folks who haven't participated in clinical trials why they haven't participated in clinical trials, it's because they didn't know about them. No one ever asked them. No one ever made the effort to let them know about it. And so, we have to commit to making sure that we're making the trials accessible to people and giving them the opportunity to participate if they want to.
Yeah, meaningfully engage the community. Yeah, again, not rocket science. So we're seeing improved health literacy. Improved health literacy empowers people affected by HIV. As a very close second is the clear materials should be co-created with communities. And Ben, any thoughts on the poll results?
Again, I think they're all valid. So yeah.
I just want to emphasize as well, even when you're approaching patients for the trials, it's understanding that they hold a level of expertise that you need, and you need to value that monetarily. If somebody's going to have to skip a shift at work, it's costing them a lot more to give you what you need. So you've got to value that. I think sometimes we've been very complacent with tokens, and I think there's the legal aspects and ethical aspects, but that becomes a barrier because then the option to help with that trial versus their cost of living or any other commitments is not balanced. And how do we make sure we value that experience so that it's meaningfully engaging the person and they feel valued, that their experience is going to be heard?
Just get the balance right, because you don't want to be coercive, right, and have something that is out of bounds. But that's the fight that you have with with the regulators and with the folks at IRB. This is, what, I should value their time. They're going to have to drive here. They're going to miss work. They have to pay for parking. You can go down the laundry list of things that makes it hard for people to participate. We should be considering all that in how we're reimbursing them for participation.
Yeah. Honor the time and value the time. Thank you, Judy.
Thank you.
I'm going to walk back with you. So now is the part of the symposium where we get to hear from all of you. We are now entering the question and answer portion. Just so you all know, we have microphones in the audience here, over there, and at the end of both. So if you want to just go to the mic, there will be someone out in the audience there that will cue me to let me know that there is someone at the mic, because these bright lights are definitely shining. But I also just want to thank each of you for your insights, your comments, and again, the passion that you show in the work you do is evident, completely evident. So thank you for that. Can we just get a quick round of applause with our panel before we do the Q&A?